name is Chadi Alraies from Data Medical Center. Welcome, Cardiology Update viewers and listeners. Today, we're going to come to you with an update for one of the largest interventional meetings happening in Europe last week, EuroPCR 2023. As you know, the attendees were more than 11,000 attendees, and a lot of great trials as well as registry reporting happened at the meeting that I think we're going to go over them one by one that can be a practice changing as we go through each one of them. Again, as you know, the meeting happened in May in France every year. So next year going to be in the second week of May in 2024. I would like to start with a structural trial is the TAVI early discharge study. This is a very important and practical trial. So the name of the trial is FAST-TAVI 2. And the feasibility and safety of the short hospital stay post-TAVI always been of interest. This is not only because it's more improves efficiency in the cath lab, but also it improves patient satisfaction not to stay longer after the procedure. And as we know, the TAVI becoming more user-friendly. We have too many devices now, and it's becoming very easy. In some centers, they discharge same day. So what they did in the FAST-TAVI trial, they investigated the results showing length of stay maybe safely reduced by 1 to 2 days compared to the current practice. And the patient discharged within 3 days significantly increased using the protocol-based care compared using usual care. And what they did, when I looked at the protocol, they have proper evaluation of the rhythm after deployment, a closure of the groin successfully, as well as pre-hydration and post-hydration, and also patient mobility right after the procedure. Granted, this is an easier study to do because we are involving more younger patients, so their functional capacity even better compared to previous trials. But at the same time, it's a good data to and practice, and I highly recommend you visit the protocol that the TAVI FAST-TAVI 2 put together if your center is high volume TAVR to increase efficiency after discharge. The second trial we'll go through is bioadapter RCT. This is a new stent, Dynamex bioadapter study, stent comparing to Resolute Onyx stent in patient presenting with coronary artery disease. And the results show 1.8% target lesion failure at 12 months, which is not different between the Resolute Onyx. And the study went up followed the patient up to 12 months and show significant benefit in plaque volume reduction by 9%, while Resolute had only plus 10% increase. However, this is kind of a 12 months follow-up. We require longer follow-up to see if these findings persist. The next trial is ADALA, ADALA. This is very interesting, and I think I'm going to start practicing this myself. This, again, guideline didn't incorporate yet, but it's very helpful safety trial. In this case, patient who underwent left atrial appendage closure device. Usually, the current practice is to give dual antiplatelet therapy, usually aspirin and clopidogrel. But the trial here is compared DOACs, which is apixaban, compared to dual antiplatelet therapy after left atrial appendage closure in patient with atrial fibrillation. So through 3 months follow-up, there was reduction there was similar reporting of thrombotic events, but there was lower bleeding events in the apixaban group, suggesting that maybe it's safer than dual antiplatelet therapy. Again, this is a 3 months follow-up trial. We need a 12 months or even longer. But again, as a safety measure, we know that these patients are high bleeding risk already. That's why they referred to Watchman to start with. But the dual antiplatelet therapy is the current practice for left atrial appendage after deployment to allow endothelialization of the device. But now this trial suggests that apixaban can be a safer and lower bleeding in these patients. Next study is Portico IDE. We're going to stay in the structural space. So Portico, as we know, is a new valve, is manufactured by Abbott, and it's a self-expanding. So in this trial, we from Cedars-Sinai, they present as a PI, they presented 5 years updated data from the Portico IDE trial, indicating that there's no difference in all-cause mortality or stroke risk for high and very high risk patients treated with self-expanding portico-transcatheter heart valve compared to other commercially available that has been already approved in these patients. There was a higher need for a permanent pacemaker, significantly higher in the portico at 1 year compared to the other commercially available valves. Again, this is another option for self-expanding valves. It has very good hemodynamics after deployment, but you have to keep in mind that the pacemaker rates are higher, and this is a 5 years data will be published soon as well. Moving again to and staying within the structural space is TMVR and guideline-directed medical therapy, or CHOICE MI and COAPT. So this is what they did in this kind of, I would call it registry or post hoc analysis. They combined these two trials, which is heart medical therapy for severe mitral regurgitation in patients with functional MR due to advanced heart failure. So these patients in the COAPT, as we know, these patients are clipped with a mitral clip to reduce the amount of mitral regurgitation from severe to moderate or even mild in certain cases, and compared to medical therapy alone. And no surprise, definitely there was significant reduction in the amount of mitral regurgitation in the TMVR group who received the clip compared to the medical therapy. There was reduction in hospitalization and heart failure symptoms also in the TMVR. However, at the follow-up, there was no difference in mortality. So better functional capacity, better link to hospital readmission rate, and also patient satisfaction and quality of life in the TMVR compared to medical therapy, but mortality is no different. Important follow-up, and I think interesting analysis comparing two intervention that still people kind of think medical therapy can work, but I think mitral clip can add more benefit as well as help to these patients. Moving again to intercept TAVI, again still in the structural space. A lot of structural stuff happened in EuroPCR, as you notice. So a primary result from the pilot intercept TAVI trial indicated that patient undergoing TAVI procedure who had carbon dioxide or CO2 flushing or TAVI valves, regardless of the valve type, experienced significant fewer acute cerebral lesions compared to those who underwent saline flushing alone. It's a very interesting concept. I mean, when you read the protocol and how they use the carbon dioxide instead of saline for the opacification and flushing of the systems, and the hemodynamic that induced these kind of microthrombi, there was lower risk in CO2. So moving forward, the question would be whether CO2 flushing can be provided for the neuroprotective clinical benefit. This is yet to be examined, and also I don't know how can it be applicable. We use CO2 injections in patients with advanced kidney disease. For example, we cannot use contrast to minimize the contrast and the peripheral space, but this is a new concept to induce this kind of CO2 injections in patients for structural intervention. Moving now, still kind of, I would say, structural slash coronary is EBC main. So a trial, a 3 years follow-up result from the EBC main trial compared a stepwise provisional strategy, as we know, to a systematic dual stent approach for percutaneous intervention in left main bifurcation. This is the patient who had a Medina 111 bifurcation lesion, and then they compared the provisional, meaning straight left main to LAD or to the main vessel, compared to two-stent strategy. The primary composite outcome is death, myocardial infarction, revascularization, TMVR, as we know, and showed no significant difference between the two approaches. And death and MI rate were similar. However, the provisional study had a significant lower rate of target lesion revascularization compared to the systematic approach. Most repeat intervention occurred in the ostium of the circumflex. This is very interesting, and I definitely, the more we go to conferences and we talk about the bifurcation approach, is there is a bit too, I would say, divided as two big schools right now. People who are believing in provisional, where you just stent the main vessel across to the left main, and other schools who would still believe in two-stent strategy, DK crush, mini crush, collat, whatever strategy, or T-stenting, whatever strategy you do. But in this study, they looked at the efficacy as well as the revascularization for provisional, and this is kind of favor that, or reassure, I shouldn't say favor, it's to reassure people who believe in provisional stenting that this is still a valid and a good strategy in these patients with left main and bifurcation lesion. Moving along to EBC2, this is the 5-year finding of EBC trial, showed no significant difference in benefit between a provisional standing approach and systemic call-out strategy for large non-left main true bifurcation lesions. So again, this is on the same space within the left main bifurcation. EBC main again compared provisional to stent strategy. EBC2 is compared the provisional to a call-out strategy for a large non-left main true bifurcation lesion. The primary endpoint, again, myocardial infarction, stroke, as well as target region revascularization, and all of them, they were similar between the two strategy. Therefore, the stepwise provisional approach may be considered preferably for these bifurcation lesions. Again, another reassuring data and findings on long-term, relatively long-term, 12 months data for patient and operators who choose provisional intervention for left main. Next study is the SMART trial, SMART trial. It's presented and assessed more than 200 patients with uncontrolled blood pressure using more than 2 antihypertensive medication. Patients were randomized to receive renal denervation or sham procedure. So I just want to stop here and give, so RDN or renal denervation intervention was really a big topic at EuroPCR, was a big topic at SKY, as well as big topic at heart failure. This is where for patients who have resistant hypertension, who are taking more than 2 or even more than 3 antihypertensive medication, assure that they are compliant with the medication, and yet blood pressure continue to be elevated. So in this cohort of patients, the patient were randomized to renal denervation versus sham. So RDN or renal denervation demonstrated non-inferiority between the two groups. Both groups experienced decrease in blood pressure with average 25 plus points in the denervation group, and compared to 27 in the control arm. Adverse events were similar as well between the two arms. Again, maybe something leading us to use this option for patients who have very resistant and blood pressure, as we know, because can be a reason and main cause for kidney disease and end-stage kidney disease. The last but not least trial is the Basilica trial. So we know Basilica trial is presented at has been presented before, and it's a technique used for kind of preventing the left main occlusion in patient who has valve-in-valve. So this is where literally they slice through the leaflet of the patient or of the prior prosthetic that was implanted before. So in this, we know that technique has been published before, it's been described before very well. But in this study, they resulted comparing the Chimney stenting to the bioprosthetic or native aortic scallop interventional laceration to prevent the iatrogenic coronary artery occlusion. So they compared the Basilica to Chimney. So just to give a background, so Chimney stenting this is where the operator preemptively wire the left main to the LAD or circumflex. They deploy or they load the stent over the wire, but they don't deploy anything. Now, then they go up with the steps where to deploy the TAVI in the valve of the patients. When they are done, then as a bailout to prevent occlusion of the left main, they do the Chimney stenting, or patient will be going for the Basilica, which is laceration of the leaflet before they deploy to avoid any occlusion and make opening in the left main after, so the new valve does not occlude the left main. So these two techniques has been different schools, again, different operators use different options. But in this trial, it's a very important trial. They compare the Basilica method compared to the Chimney stenting. So the study found a trend towards a higher risk of cardiovascular mortality with the Chimney stenting, 6.7 compared to 1.3. Despite Basilica requiring more specialized training, because it's not an easy, straightforward procedure, and only a few centers in the United States and a few centers in Europe that can do this procedure and techniques. Is not the equipment issue, is more of a skill issue. The technical successors were similar, 96 and 98. However, granted, these are done in high volume centers and also in centers where there is a practice of Basilica is the norm. However, 1 year 10 basilica patients require bailout coronary stenting for safety reasons, Chimney stenting, and more pre-procedure complication, including the high risk of minor bleeding, acute kidney injury, and need for permanent pacemaker happen in the Chimney. These findings suggest a need for further study. So in this trial, it did not favor one procedure or strategy compared to the other, but what it shows that in certain patient selection for one strategy is over other, and also show favorable outcome in patient who underwent basilica compared to Chimney stenting. With that, I know it was a long video. I hope you find it helpful and also give you an overview of what happened in EuroPCR. There is a lot of studies happened before, but this is what Cardiology Updates picked for you. I hope you enjoyed it, and please subscribe and share to the social media channel that Cardiology Update has, and I will see you in the next video. I am Chadi Alraies from Detroit Medical Center.